webinar in our series, A Targeted Approach to Reducing Environmental Cancer Risks in Pennsylvania. My name is Andre Green, and I'm honored to be your host for today's session. I serve as the Associate Director for the Cancer and Environment Network of Southwestern Pennsylvania and as an at-large member of the Environmental Health Work Group with the Pennsylvania Cancer Coalition. Our primary and central objective is to strengthen public protection from environmental carcinogens and cancer risk factors. This entire series is actually a collaborative effort between the PCC and the Cancer and Environment Network. And now I would like to turn our attention to today's speaker and the topic. We are incredibly fortunate to be joined by Nathan Worth, the statistical analyst at the PADEP, for the critical topic of a data-driven deep dive for professionals. Nathan will highlight data resources such as EDDI data and how this data translates into actionable strategies for cancer risk reduction and public health interventions. We also encourage you to submit any questions you have throughout the presentation into the chat, and we will address them during the Q&A session immediately following Nathan's presentation. Now, without further ado, Nathan, the floor is yours.
All right, thank you. Let's start the screen sharing. Oh, where'd it go? There it is. Hello, everyone. I'm Nathan Worth, a statistician with the Pennsylvania Cancer Registry. Today, I'll be showing off our tools for querying and analyzing public health data. So our most general and useful data tool is EDDI. So that's going to be the first topic of the presentation. You'll see how to query the data, understand the output, and use it for your work. After a brief demonstration of EDDI, we'll cover some other data sources, and in particular, we're going to look at the Pennsylvania Cancer Statistics Dashboard. So for an overview of EDDI, EDDI is our Enterprise Data Dissemination Informatics Exchange. And this is because prior to EDDI, the DOH published health data across our website, and we had multiple tools to query that data. And so users had to memorize how each tool worked, had to know that each tool existed. So EDDI was our attempt to just get everything in one place and make it easier to use. Now we collect most of our data and even new data we publish into this single database, and then they put a query tool on top so that anyone in the public can query these aggregate statistics. Each table still has its own set of demographics and characteristics that are appropriate for that kind of data, and that allows users to choose what subsets of the tables they want the statistics to show. And the link in the bottom right of this page, of this slide, will take you to the landing page for EDDI. And even if after this presentation you still have questions about how the data is collected, all the things about that, how to use EDDI, that landing page has FAQs and video tutorials. So the first step in making an EDDI report is you got to choose what kind of report you want to see. So in the leftmost selection list here, this is how you would filter down what data sets you see. You don't need to make a selection, but it's useful if you want to know what we have in diseases, like which of the data sets is about diseases. The second list, it says category, but really it's choosing the data set by name. Some of the data sets can have very similar topics. For instance, there is a cancer incidence data set, and there is also a childhood cancer incidence data set. We kept them separate because the demographics and the types of data they show are different enough that it didn't make sense to put them in one data set and have one menu for querying them. The third list here is you select a region size that you want to see aggregates for. County state is a very common one. Some data sets have municipality level data, and other data sets have unique regions for themselves, such as the behavioral risk factor surveillance system. It has its own regions that are groups of counties, and so you can pick that for that data set. And the last list report is you choosing how you want to see the data. The table is the most customizable form for it, and it lets you choose a different mix of demographics. Charts and maps are more restrictive in what they let you choose, but everyone knows visualizations are important. So just to give a brief overview of how table reports look, they're just plain rows of data, just the facts. They'll include columns with the demographics, the dates, counts, rates, other statistics that are included. You can choose different statistics you want to see and make new tables. Rates will often come with indications of statistical significance. And for most data sets, the baseline that they're being compared to is the overall state rate for that demographic subset. And if the rate is higher than the state, statistically significantly higher, it will be highlighted red. Blue means lower. And at times, we're going to show not displayed. That's if the rate is based on a count too low to be reliable, or if we're trying to prevent personal information from being leaked. You can make pretty large data sets. I've been able to make ones that have 10,000 rows. It just takes a long time. Uh, if you try and make a large data set, the server's going to take a while to give a response, and sometimes it will just quit and you got to start again. If you really need a lot of data, try and break your query into multiple queries and then just save each one separately. And you can save them. You can export them as a CSV, the comma separated values, or you can export them to Excel files, and then you can use them in your own statistical software or however you want to analyze them. So the chart reports is the first visualization. Like I said before, you won't be able to select multiple choices for different categories or demographics. We restrict it pretty well just because it makes it easier to display. Uh, you can include the table of corresponding data beneath the chart, and charts can be exported as image files. They're TIFF files, which is not a common format, but it works just fine in Microsoft Word and other image, anywhere you can use an image. They can also be exported to Word files themselves, but usually TIFF is good enough. Our map reports, these are choropleths. So they use colors to show where region statistics fall along a scale. Uh, this slide, I have it written down that they're county level. That's not always true. There are maps like for the BRFSS where it has its own regions. You can show maps by those regions. The colors on each region correspond to the distinct which distinct range they fall into. The ranges are chosen by an algorithm, and you can change what kind of algorithm you use for whatever's appropriate and gives a good looking map. And it's useful. Uh, if a statistic is suppressed, then you're going to see that region grayed out. Like you can see, it's hard to read, but Forest, Cameron, and Sullivan counties are grayed out. So they've been not displayed. And just like charts, you can export maps as an image file, and you can include the table beneath them. So this is the expected schedule of when we're going to update our EDDI data sets. We do publish this on that landing page link that I shared before. There is a link to a list and it shows you when we expect to publish it, and we update that list every year. So if there's any change in the expected update schedule, it will show up there. The only thing, I'm not going to read this all out. The only thing I'm going to make a note of is communicable disease data set is going to get 2 updates this year. One in the third quarter has the 2023 diagnosis, and another one in the fourth quarter with the 2024 diagnoses. So now I'm going to try and do a live demo of EDDI because it's instead of just using slides, it's better to see this kind of thing live. So if you go to, I'll go back to, we'll go to the Department of Health. If you go to the Department of Health website, on the left side, you can choose health statistics, scroll down, EDDI, and Eddie about. Zoom in. All right. So this link up here takes you to the Eddie page. As you saw before, this is where you can select. So demographics, 3 data sets there, environmental public health tracking. This is its own program, so they get their own category. So we'll go for all data sets, and we'll do the one I know, which is cancer incidence. We'll start with county state, we'll do a table. So let's say we're investigating something like uh, early onset colorectal cancer, because that's been a big topic in our cancer prevention program. So here we can see all the different sites. And if you want to know anything about any of these categories, what you can do is the labels for each one is a link to the technical notes. So there's the technical notes for primary site or type. It describes it. It says what kind of categories we have. It's a link to the ICDO codes. So these are the codes we use to define the sites. And, ICDO codes are specific for cancer, but all other data sets, you can click on these and they will give you the definitions and notes, warnings for that data set. It's extremely useful if you have any questions. So anyway, we're going to choose colon rectum. We're going to keep this Pennsylvania, but we could select multiples. Actually, Pennsylvania, Allegheny, Philadelphia. I'm always guaranteed to get statistics for those. We could choose multiple years. We do total, all race, age-adjusted race. We could also do percent stage. These creates different ones. And here you can see that some menus change based on our selections in other ones. So do age-adjusted rate. We'll do under 40. We'll do under 50, over 50. And we'll keep that invasive stage. So there we have our table with all the different combinations of our selections. There's one rate that's statistically significantly lower. There's one that's higher. It looks like we don't have any suppressed here, which is nice. Expected counts are suppressed for Pennsylvania. For the cancer data set, expected count means like if it had the same rate as Pennsylvania, what would it be? And of course, we don't display that if it is Pennsylvania. Its expected count is its count. This little hard disk is where you choose how to save the data. So like I said, you could do Excel, Word, Excel, PDF, CSV. I've never tried to export a table as an image. It doesn't make sense. So we could do Excel here. Open that up. You can see there's the entire table in Excel. And you can do your own little calculations here, just like any normal Excel file, like that. All right, let's just close that. Don't save. Okay, so for the charts, the communicable disease chart. Here we can look at hepatitis B. And all right, so we can select, in this one, we can select multiple counties. So again, I'll do Allegheny, Pennsylvania, Philadelphia. Let's go by 3 years. Make sure they don't overlap. Total sex. So I can't select multiple sexes. Again, usually a chart will let you select multiple categories in one demographic. Aside from year, you can always select multiple years, but then we usually let you just choose multiple categories in one demographic. So here I'll do male, can't do multiple races, all race. Oh, this one is a warning on missing values. So that takes you to a page that tells you about, a warning about race and Hispanic and ethnicity data. So all ages, let's do a trend line. I can make of those. And we'll leave that showing the table below the chart. So you can see the trend lines. There's the table with the relevant data, and I export that to a TIFF. Open that up. And it's just going to have the chart. It's not going to have the data beneath it. So there you can copy that, put it in a report if you want. And it's got all the notes and all the selections you made. So it looks pretty nice. Okay. Map would be the same kind of thing. Oh yeah. So I can only select 1 year for the map. You can only select one category for all of these because you're going to get one map. For the table, data classification. So optimal is the default. It's a very good default. Equal interval just tries to take the range from the lowest rate to the highest rate and then split it up into whatever number of classes you have. And then the counties fall where they may. It's not really great. Sometimes it's good if you want to show that one county is a complete outlier. Equal distribution tries to put the same number of counties in each one. All right. And if you ever forget these things, again, just clicking on this, it has the technical notes. You can see what each algorithm does. Oh, yep. Okay. So here we don't have enough data for Philadelphia. So all the other counties are suppressed. Was it chronic I did before? The website's kind of slow today. There we go. That's better. So here you can see how things fall into different categories. It's a nice choropleth map. A lot of counties are suppressed. You'll generally see that with Pennsylvania. We have a lot of counties that have very, very low populations. Okay. So that's the walkthrough of Eddy. Move on. All right. So the next tool we're going to explore is the Cancer Statistics Dashboard. While we do publish a lot of cancer stats on Eddy, the dashboard has all of it pretty much and a lot more. It's where we recommend that people get cancer incidence data for Pennsylvania. We'll always keep Eddy updated for as long as Eddy exists, but this is something we update every year, and this is where we point people. Eddy is kind of there in case you're already reliant on Eddy. You need to make large specific tables, or if you need data that's only in Eddy, some data is only in Eddy, very small demographic groups. We generally just don't publish in the dashboard, but you can find them on Eddy by making the query for them. The link on this slide up there, that'll take you to the landing page for the dashboard. On the landing page, you'll find the technical notes for the dashboard if you need to know those. In a few minutes, I'm going to do a walkthrough of the dashboard. But first, I want to go over two different flavors of rates that the dashboard offers. So Eddy offers the basic age-adjusted rate. We don't do much more beyond that. The dashboard it's much easier to update and change and keep up to date with newer statistical methods. So one of them is delay adjusted rates. The registry, the Pennsylvania Cancer Registry's data collection process, it takes a long time. It takes 2 years after the end of a diagnosis year until we use that diagnosis year in statistics. And people do complain about this. It's a way we make sure the data is very, very good and reliable. And our data is very, very good and reliable. But even given 2 years that places have to submit a record, and they're required to submit it within 1 year, a lot of facilities will still report it after that cutoff period. So it will not show up in Eddy statistics because we don't update back years of Eddy statistics. Once it's made Once I publish once the 2023 diagnosis year data comes out, that's what it's going to be forever. The dashboard updates its data every year. So 2023 diagnosis year, next year when it's updated, it's going to be new statistics for that based on any cases that came in past their deadline. We try to also account for that by using delay adjusted models, which are models that help us guess how many reports have still yet to be reported to us. And this correlates very strongly with the type of reporting facility and the type of cancer because of the type of reporting facility. So, for example, laboratories doing pathology tests report their data. They're more likely to have late cases than other kinds of facilities. Hospitals are usually very, very quick, but laboratories are kind of later, and a prostate cancer shows up more than other types of cancer in laboratory reports. So prostate cancer data is often more likely to be late reported. So delay adjustment models help with smoothing that out and preventing those biases from the delays to give you a false sense of the trend. So if we did not delay adjust them, it would look like the trend might be going down when it's actually staying flat. So the delay adjustment would be like, okay, but you got to bump up for what's yet to come. And so here's an example using prostate cancer, like I said. So you can see on the left was the what's called the observed. Oh, yeah. So whenever you can in the dashboard, you should look to see if there is a little menu saying rate type. Choose delay adjusted. And I really recommend go with delay adjusted. It prevents mis uh, mis problems with analysis and getting the wrong idea of what's actually happening. So for this example with the prostate cancer, here you can see this is the observed, what's actually in our database, the number of cases, and then age adjusting that. And then here is with the delay adjusted. So you can see it goes up. So here it kind of looks like it's kind of staying, after that little dip, it's not that big difference there. But here you can see it's actually still kind of continuing that line. And that dip is COVID. You're going to see that in a lot of our trend lines. You're going to see 2020, huge dip in diagnoses. After that, back to normal. Uh, our models for delay adjustment just omit 2020. They don't even try and use them. It's just going to throw everything off. The other flavor of rate is the model trend. Again, this model also throws out COVID 2020. So everyone knows, like, if you look at the trend lines, they're up and down, up and down, up and down. You kind of have to eyeball, or you might choose like, oh, just 10 years ago, and then choose how, like, and then you'll see what percent increase was it over just 10 years, just an arbitrary number. Well, we are using software from we're using software from the CDC to create what are called joint point models. Now, these models break the trends into segments, and then they give the average annual percent change for those segments. This allows you to compare changes in different segments or between different groups, even if the segments are not the same length. And the segments are chosen used by the model to break at inflection points and say, like, okay, there's definitely a change in trend in this year. So that's where the segment should break. If you're going to compare trends, this is good because the AAPC, average annual percent change, is really easy to compare them. They're nice. They're made for this kind of thing. It's just much easier than going with the eyeball or the arbitrary cutoff point. So here's an example of the joint point model versus the actual rates. So in the left, we have the delay adjusted actual rates for thyroid. And you can see with the females, you might be able to say, okay, it goes up, kind of flat, but like you can see that it starts going flat there. But where does the trend down really start? And how does that compare with the males? And here with the model, you could say, okay, there's one segment. That might be two segments there. And that just goes up. And in the dashboard, when you hover your mouse over things, you'll be able to, they have a little pop-up that appears and shows the data for what your mouse is over. So that's really nice. It doesn't show up in pictures. Uh, but here you can see it goes up. And then in 2009, the female doesn't really plateau, but then starting in 2013, it has a nice sharp dip. And the male starts up with a slower increase, gets a little bit more, but then starts dipping in 2010, just keeps going down that trend. But for these last segments, even though they're different length, you can see the the rate of decline for a female trend is twice that of the male trend. So it lets you say that. So that's really nice about average annual percent changes in these models. All right, so now I'm going to do a demo of the dashboard, and it will also show you all the different kinds of statistics that are available there. So going back to the health statistics page, and if you go to the Department of Health, this whole menu is available over here. So you move to health statistics, cancer dashboard. And like I said, here's the technical notes, details about all the different statistics we have. So you click go to dashboard. If you're going to make a bookmark for this, bookmark this page. Don't bookmark the dashboard. We haven't figured out how to make this a consistent URL. It's always some long identifying string given by Microsoft Power BI, and this is going to change every year. So if you're going to bookmark anything, bookmark this page. So the first page of the dashboard has summary statistics. If you don't have much time, you just want the summary statistics, you just got to go to the first page. Everything here should pretty much meet your needs. You could choose the different cancers you want to see. If you pick a sex-specific cancer, it's going to show like this at first. You might wonder why. It's because you're showing it for all sexes, and that's not a valid choice for prostate cancer. You got to pick male. So here we see the incidence statistics, number of cases, age-adjusted rate, rank of new case count. So out of all the 23 primary sites we really look at, what's its rank by case count? Prostate cancer is number 1 for men. The median age of diagnosis, the lifetime risk. So what's the chance that a man who does not have prostate cancer, what's the chance that a person born this year or in this era, 2019, 2022, born in that period, what's the chance they're going to get prostate cancer in their life? And it's 1 in 9. And the average annual percent change that gets for the last 5 years. Mortality, similar things, rank death, median age, lifetime risk of dying of that cancer for someone born in this period, and average annual percent change. The prevalence, so this is the number of people alive with it today in Pennsylvania. And here it is 37 years. That's probably because of how far back our data in the registry goes. It really only goes back to like 1987, 1985, like 1987. But 1990 is when I find is a good cutoff for what's actually useful. And survival, we do publish net 5-year survival rates. So the net 5-year survival rate is hard to explain. It's a complicated concept. It's a best concept for comparing rates, and I'll get to that when we get to the page for that. So each of these statistics can be found on another page of the dashboard. This just collects them all together. Ranking is just number of cases. Very simple. And yeah, I'll keep things moving so we can get time for questions. The trend summary is just the average annual percent change the past 5 years in the most recent 5 years data. So then it just ranks them. Here again, delay adjusted. Here, if a trend is not statistically significant, It's shown as gray, uh, and statistical significance just is whether or not we can say there is a change. There's got to be a change. It's just, do we know which direction? So the trend line, again, this all says, you know, our models do not use 2020 because of COVID. That's going to show up in a lot of things. So it starts you off with the incidents modeled, observed. So we could do delay adjusted. We make models for the delay adjusted. Here you can choose different categories for what kind of thing you want to see. So here we're comparing Pennsylvania, United States. What if I want to do it just for male and black? And here you can only make one selection. And that's because we're comparing by geography. If I want to compare races, I would choose race over here. And then you could do one selection, male, one geography, Pennsylvania. And now for race, now it's a checkbox. I can choose multiple. I can do all white, Hispanic. Hispanic for us includes black and white. If a person calls themselves white Hispanic, that case will be counted for Hispanic and for white. And here you can have the tables. Uh, there is no way to export these charts as an image. I wish there was, and I'm still waiting on Microsoft to do something like that. So what I do is there's a snipping tool on Windows. I don't know if Apple has something similar. You could also choose print your screen. So here I use a snipping tool. I can select what I want, and then I just have that. And here I copy and paste into whatever I need it to. In the top right of charts and tables, there's a little, I'll zoom in so we can see this. It did not grow. It's the same size. There's a little square with an arrow in it. If you click that, it opens up the chart full page, makes it easier if you want to take a screenshot. As I said, prevalence is number of survivors alive today, expected alive today. We base this off of combining cancer incidents and death records. And the registry is very good about collecting death information from other states. So we're pretty confident in knowing when when someone was in Pennsylvania and diagnosed with a cancer, if they are still alive. We're very confident of that. We're not confident if they still live in Pennsylvania. We are not an active follow-up registry. We don't keep calling people or checking in on them. We rely on records that just come into us. And again, you can see like Adams Allegheny. Make charts by that. Prevalence time, you can see. So how many people within 5 years, how many people have between 30 and 35, how many of those people who were diagnosed that long ago are still alive? Stage distribution. This is available in Eddie. So how many people get melanoma, early stage, late stage, or unstaged? You can compare by cancers, you can compare by sex, or all cancer sites. Yeah. So same idea. Those other pages. The dashboard has fewer choices for age groups than Eddie does. Eddie has a lot of choices, and some of them are based on recommendations from the U.S. Preventative Health Services Task Force. So before, when I was showing the colorectal rates, and I broke it between less than 50, over 50, that's because of the age cutoff or the starting age for the recommendations for different cancer screenings. We've added those to make it easier in EDDI for people to get the data that is relevant to what they want to talk about. The dashboard doesn't have those kind of ages. The dashboard, all children put together, and then 10-year groups. This is kind of like stage distribution, except across age groups. And this is where you can most frequently diagnosed between 60 and 69 for all cancers. 5-year survival. So here I'm going to actually give the very brief rundown of what net survival is. So net survival is what we'd expect what percentage of people we would expect to survive 5 years after being diagnosed if it were impossible to die of anything but cancer. And we do this by comparing the overall survival of any cause among people diagnosed with cancer, and then comparing that to the overall survival any cause of the general population that's the same age, sex, and race. And then we use those and we find the difference and pretty much figure out from that difference what it would be if cancer were the only possible cause of death. So it's not a statistic that is reflected in the real world at all. So you cannot say that, oh, the 5-year that someone diagnosed in 2017 with lung and bronchus cancer has a 30% chance to survive 5 years. That's not true. It's going to be a little lower because this excludes all other causes of death, such as heart disease, accidents, those kind of things. But it lets you compare statistics to other statistics because the chance of dying of other causes is very highly correlated with the type of person, with age, with sex, things like that. So here you can see the curves for year diagnosis and the 5-year survival rate. You'll see that it only goes up to 2017. The other charts have been going up to 2020 or 2022, and that's because we need to have 5 years after the diagnosis to get a good sense of their rate of survival. And again, you can compare by different categories, by stage of diagnosis. Comparing by stage of diagnosis for survival is tricky because the 5 years starts when they're diagnosed. So if someone's diagnosed early stage, it may look like they have good 5-year survival, but like have better 5-year survival than someone diagnosed late stage. But is it that just because of the years the cancer did not have to progress to a late stage? That's a tricky thing to compare. So that's 5-year survival. Here you can see survival by time 6 diagnosis. So not just 5, like there's the 5 years, but you can see 1 year out to 10. And again, you can compare by the different categories. This is a nice page. I always like this one. So the probability of developing and dying, it's just nicely laid out. It's easy to interpret, and it's got these little cards that you can, again, do a screenshot or just or I can't even select the text. So you just copy it by typing it in to whatever report you want to include it in. Here you can see charts of them. So that's a nice summary. There's risk interval charts, risk comparison charts, maps. So it's like what it's in EDDI, observed. Okay, so observed, we don't have delay adjusted we don't have delay adjusted map data for maps. Here, observed is all we have. We also include projected. So like I said before, some people don't like that we're 2 or 3 years behind in data. This year we'll be publishing 2023 diagnoses, even though it's 2026. So what we do is we do a projection for what would the rates be in this year. And the dashboard still is updated for 2026, so it's using 2025. So we use the data that we had to project out to 2025, and this is where we expect increases, decreases, and changes, comparing them to 2022. Which one's going to go up? Which one's going down? Which one we don't know about? We do that for incidence and mortality. And then on the next page, you can just see the projections with the trend line. So here goes to 2022, and then what we project based on models. And you could do that for incidence mortality. For the overall state, here we do it for individual counties. For the county ones, we don't do it by cancer. That the models wouldn't have enough data to really be good if we did by county and cancer type. It takes a lot of data to make a good model, and at that point, it's not really reliable. The last selection here is data. So this just lets you, this is its own query system. You can query and make up your own tables. And this is based on almost all of the data that is available throughout this dashboard. So the dashboard shows, every other page shows nice visualizations, nice summaries. This is if you want to just have kind of like eddy tables. And you can change what kind of data you want, and then all the selections to get what you need. And the last thing I'm going to show, back on the overview page, down here is a link to revision history. So if we make changes in how these statistics are done, that's going to show up there. So if you notice that something's weird, check the revision history. Make sure we didn't change something that's important to you. Technical notes I showed. Download dashboard data. So we made it so that we wanted to make sure that people could have the data they need. And it's not easy. Like I said, you can't download it from Power BI. So we just made a zip archive that has, it's huge. Okay, I think I was going to download it, but it's actually 288 megabytes. It's large for a web download. This has every single piece of data that's throughout this entire dashboard, and they're in different files and different tables, and it includes one file that describes every single table, what columns it has, what's allowed in there, what definitions. If you want to analyze this data yourself in Excel or SAS or what have you, you can download the dashboard data. Personally, I do this too. If I'm doing data requests, I'll come over here, I'll download the dashboard data for the year, and I'll just use that to fulfill the data request. It's just a very good resource. And that's for people who are comfortable dealing with just large tables of data themselves. Let's get back to the PowerPoint presentation. Running out of time. I'm going pretty past time. So actually, I'm just going to do this really quick. Other data sources that I found useful and recommend to people, we do county health profiles. These are high-level summary statistics by county, and each county has its own page. There's no narrative, no description of what it is. It's just tables of data across different kinds of statistics. It's updated annually. You can download all the data that's there. Our health statistics A to Z, if you want to know where to find data about a certain condition or group, go to our health statistics A to Z. It's linked on our health statistics page, and you can look up that term. We have over 300 terms in that listing, and it will have a brief definition of it, and then links to, if we publish data, it will have a link to that data. And if the federal government publishes data, we'll have a link to their data too. So you'll be able to find information on it. And the last one is the CDC's BRFSS, which is the annual survey of so many health things. They have a web-enabled analysis tool, and I use this too. This lets you do cross-tabulation. I find it very useful. So for people who need to know, what's the screening rate for colorectal cancer screenings in younger people versus older people? We don't have that on Eddy. We can't make that for every single combination, but the CDC's tool lets you find that out, and it's incredibly useful for that. So that was the presentation. I hope you found some sources of information that you can find useful and will help you in your work. I'm very happy to help if you have any questions about anything. If you have a data request for specific cancer data, you can't find it on Eddie, can't find it on the dashboard, reach out to me. We only publish aggregate. We only do data requests for aggregate counts. I won't do rates, and that's because we let the researchers pick their own populations for things like that. But if you have a very specific kind of cancer, a very specific area, and you need to know the counts, reach out and we'll help you with that. And we'll help you with any questions you have about health statistics or finding any kind of sources or anything like that. So there's my email, and thanks for inviting me. I've been happy to present.
Thank you so much, Nathan. This was incredibly informative, and we're just so appreciative to receive this information. Um, we are now going to transition to our Q&A. So if anyone has any questions that they would like to ask Nathan, you can either unmute, add it into the chat, or raise your hand. So we're open to questions now.
Hi, this is Victor from Delaware County.
Hi.
Thank you for the presentation. I was wondering what would be the best way to submit an application for when we're looking at cancer clusters in small areas, for example, in a street or um, a number of blocks. What would be the best way to put together an application to get the data? I'm looking for leukemia. Children less than age 20. We have some questions from residents about a number of cases within a small area, like a street. So, what would you recommend us to do regarding trying to get data so we can calculate the standardized incidence ratios?
I've started back sharing the screen because I mentioned the data request, and I should actually show how you do this. So on our website, if you go down to contact us, and it's contact us for health statistics, we kind of bury this because we don't want everyone sending requests instead of looking at all the tools we have. At the very bottom is contact us form. So this is our data request form. So if you, like I said, if you wanted the counts for a certain area for certain cancer, you'd fill out this form, prove you're not a robot, and then you'd submit it. It would send us an email, and it would probably get redirected to me or one of my colleagues, and we would reach out to you and help you figure out if we can provide this. Again, if we're providing aggregate statistics, we aren't going to provide anything that could reveal personal information about a patient. If you do need if you do need statistics that would be personally identifying, we do have a process for that. If you, uh, Andre, is it possible that I could send out an email later? Because I know the Department of Health has just recently been updating our process for these kind of data requests. And I want to make sure I get it right before I tell everyone what to do.
Of course, yeah, definitely.
Okay. So yeah, we do have a process for starting. We're going to have a new process for starting those requests, but the registry does work with researchers and it costs some money and it takes some signing of legal forms saying that you're not going to share this data, but you can get that data to calculate whatever you need to on your own. And then we're also going to have a new process for reporting and tracking cancer cluster concerns because that's been popping up more and more, and we're trying to make the concerns and the requests for investigation have been popping up more and more. So we're trying to make a better process, a more formal process to take care to help people with those and track them and record them so we know what's going on too.
Thank you.
There's a question in the chat about the timeline. I do not know the timeline for when the cancer cluster process is going to be official. right now, I know if you contact the epidemiology department or if you just contact the Department of Health, it will get routed usually to epidemiology. And that's what they've always been doing that for as long as I've worked in the state, and that's over 10 years. And I'm sure they, as long as the epidemiology has existed, I'm sure they've done this. We're just changing, we're trying to have a more formal process than just rerouting emails. But right now, if you email the Department of Health, it probably will get to epidemiology and they'll reach out and help you with that if you need those if you have cancer cluster concerns.
Nathan, I have a question regarding the EDDI system. So I know a few points during your presentation, you mentioned that the cancer statistics dashboard was updated yearly. Thinking about the EDDI system, how often is that updated to reflect the latest data?
Eddie is updated every year as well. So the way the way my work timeline works is in October and November, I'm given the large data set that we're going to submit to the federal government of where they track cancer statistics. I'm given that. I help clean it and make sure everything's good. We submit that to them in November, and then they start working with the data. But as soon as we submit it, I start making the updates to Eddie. And previously, and nowadays, it's usually February or March that the updates come to Eddie. It might be a little later this year. They took a while longer than expected. So, but I'm hoping this March is the 2023 diagnoses will be in Eddie. And in coming years, it should be February or March that they'll be updated. The cancer dashboard gets updated near the end of September, usually August, because it's so much more information and so many kinds of complicated statistics that verifying it's correct takes a while. Generating it takes a while. So that usually comes a lot or like 6 months after Eddie.
Thank you. Do we have any other questions for Nathan today? It looks like maybe not. In that case, I wanted to go ahead and extend gratitude to you again, Nathan. This was an incredible and such an informative and in-depth conversation, and we really appreciate your presentation. My organization actually used Eddie Data a couple years ago to update our cancer statistics with our interns, so it's been incredibly valuable for my organization. And so just really excited to continue to use this resource and really thankful for all of the attendees for joining us today. This session has been recorded, and I will send out a follow-up email with the link to the recording, as well as all of the resources shared today. And then Nathan, you and I can connect with some of that additional information that you mentioned earlier, and that will be sent to everyone as well. Until then, I want to thank everyone again, and we will be in touch soon. Amazing. Thank you so much, everyone. Have a good day.
Have a good day.